Hello, everyone. My name is Ed Kaplan. I'm a professor at Yale University at the School of Management. I'm an operations researcher, and I'm here to talk to you about the use of operations research models to support local decisions. I became involved in this by being recruited to a Yale University committee to advise the university on public health matters that were related to the COVID outbreak. And much of this committee work involved the use of what I call scratch modeling, the use of models from operations research and applied probability to inform some committee recommendations and university decisions. Some of that modeling expanded to support the local Yale New Haven Hospital as well as the state of Connecticut. And in fact, the entire past month of May has been dominated by the use of models in support of possibly returning students to campus, in particular in analyzing repeat screening programs. Before I continue, I just want to emphasize this is not typical research. This is not something where one has the luxury of spending months to try and get the analysis exactly right. Often what was required here were quick decisions, and so we're talking about analysis being conducted over a period of 1 or 2 days typically, as opposed to months. Here's what this original committee looked like. The original chair, Paul Jennison, is the director of Yale Health, which is the health plan that serves the community. It included 3 deans from Yale of public health, nursing, and medicine, numerous infectious disease control experts, the president's chief of staff, and others. At this point, the committee now falls under the direction of the university's vice provost for health affairs, Dr. Stephanie Spangler. We started meeting with morning phone calls, and now, like everything else, we meet on Zoom daily, 7 o'clock in the morning. We have been doing this nonstop since the first part of March. Here are a number of different issues that this committee has addressed. I won't go through all of them, but just note that the issues which are highlighted in orange here are all topics which involve modeling support to help resolve the issues and reach a decision. Some of this, as I mentioned before, is still ongoing. I'm going to just walk you through a few examples of this. I'll go easy on the math, but try and give you the context of the problem, a sense of the environment in which the analysis was taking place, the results, and how it helped people make decisions. So we'll start March 7th, which is about 3 months ago. Members of the Yale community received the following email telling them that there was new information about Yale's response to coronavirus. And in particular, they were informed that all Yale-hosted events other than classes with 100 or more participants were going to be postponed. Effectively, this was putting a crowd cap on the number of people allowed to any Yale-sponsored event. So what was going on here? Well, a very simple public health goal is that you don't want any new infections to occur as a result of a sponsored event. And there's 2 ways that that can happen. You can achieve that objective if no infected person has joined the event at all, or if it turns out that there's at least 1 infected person who comes in, but no transmission ensues. The sum of these probabilities is going to give you the probability that no infections occur at the event. The second of these, of course, is what social distancing and infection control recommendations are all about. But the first issue can be directly controlled by limiting the number of people who join, because the probability that no infections occur will be at least as large as probably no infected persons walk through the front door. And that's what you can control by limiting the event size. We adopted a criterion that we wanted to have a 99% chance at a minimum, so at least a 99% probability that there would be no new infections, which gave a very simple formula for capping the crowd, which was that you can't have more than 1% divided by whatever the prevalence of infection was believed to be. So that gives you a very simple formula. It gave the university a very simple way of understanding how crowd capping could be rationally pursued. There's just one small problem, of course. No one had a clue what the prevalence was. This discussion is happening in the first 2 days of March. The first of the community transmission cases in the New York metro area, which is a lawyer from New Rochelle in Westchester County, had only been reported on March 3rd. First Connecticut case had not yet happened. So we were trying to imagine this without knowing for sure that there were infected persons in the state, although everyone believed they were there already. But it turns out that you don't really need to know what the prevalence actually is. What you need to decide is how large a prevalence you want to defend against. And so the idea was to try and cap the crowd so that a prevalence which was at that level or smaller would still give us at least a 99% probability of having no transmission. And people were comfortable with 1 in 10,000 as a prevalence of infection at that time in the very first days of March. Remember, no cases have been observed yet, and it was that 1 in 10,000 prevalence, which is what led to the crowds being capped at size of 100, which lasted for about 2 weeks. Here we're fast forwarding a couple of weeks, and there was pressure to try and reduce the crowd cap. People outside of the committee were pushing for a cap of 20, but the question was, does that make sense? The first faculty COVID case had happened on March the 14th. So why would there be such a sudden move in 2 weeks to go from a crowd cap of 100 to 20? There's actually a fairly simple rationale for it. Early epidemic growth in China had been estimated as 10% daily, and we had no independent information that was pertinent to the situation in Connecticut. But that 10% daily growth rate implied that the epidemic would quintuple every 16 days as long as that exponential growth was going along. And if we wanted to defend against a prevalence of 1 in 10,000 2 weeks ago, we should be thinking about a quintupling up to 5 in 10,000 now. And 5 in 10,000, of course, means that your maximum crowd size will be 20. And so actually it made perfect sense to do that. The very next day, of course, it was announced by the president that there should be gatherings, no more gatherings of in excess of 10 persons. And so Yale followed suit, and that ended the crowd capping adventure. But while all this was happening on March 7th, a rather influential interview came out of Italy, where the head of intensive medical care for the Lombardy region of Italy, which is what contains the city of Milan, that interview revealed that in a thoroughly modern Western hospital system, there were coronavirus patients in need of intensive care with negative pressure units to try and ensure that contagion would not escape. And instead, these people were being boarded on gurneys in the emergency rooms because the hospitals were simply out of capacity. And this, of course, caused a bit of a shockwave locally. The question was whether or not the Yale New Haven Hospital would be able to withstand such a wave. So the same day that this information came out, I proposed that we conduct a stress test at the hospital, where the idea was to figure out how many COVID patients the hospital could handle. This was not an exercise in trying to forecast how many COVID patients there would be. Rather, it was to ask the question, if we saw a certain arrival rate of COVID patients, could the existing ICUs at the hospital handle this? We had to, first of all, find out how many people were already using those ICUs. They're 90% occupied. Remember, we're in March. This is already still influenza season. And there's an anticipated range of lengths of stay in the ICU. There wasn't sufficient information on how long people stayed there, so we took a reasonably wide range from 3 to 10 days. And so the question was, what could the existing ICUs handle? And we focused on the likelihood that a patient would be blocked, that is, they would not be able to obtain a bed because they would all be filled, and hence end up on a gurney in the emergency room, just like the situation in Italy. Well, queuing models are often used to study ICUs. This is just one paper of many. The loss in these Erlang loss models refers, in fact, to patients being blocked, not being able to get a bed. And Erlang, as some of you might know, is a famous Danish engineer who pioneered this type of modeling in the context of a telephone system. Time ago, being blocked here meant that one couldn't get a dial tone. So here's the sorts of findings which came out of this very quick analysis. Notice it was requested on the 7th of March, I should say proposed on the 7th of March, and delivered 3 days later. Initially, we focused on the medical intensive care unit, which had 25 negative pressure beds, but taking into account existing occupancy, it would not be enough, even if there was only one COVID patient per day in need of the ICU. That would not be enough to prevent blocking 30 to 40%, meaning that any patient showing up would have only a 60% chance of getting a bed, 30 to 40% chance of having to be locked out. Looking at all of the existing negative pressure ICU units, of which there were only 57 in the entire hospital, could cut COVID blocking to manageable levels if you only had one daily arrival. But of course, if there were 5 patients coming up or more, then it would turn out that there would again be significant bed blocking. And plus, these 57 units were scattered all over the hospital. So that would give you a considerable infection control problem if, in fact, they were all to be filled up with COVID patients. So this analysis helped convince the hospital that they needed to reconfigure or repurpose some of their resources. And what they did was they took 3 floors of the cancer hospital and were able to create a dedicated 84-bed negative pressure COVID ICU unit. And this could handle up to 13 or so COVID patients arriving per day who need ICU care without any serious bed blocking. And in fact, it was exactly these preparations that saved the ICU from overflowing. The beds did in fact fill up to the maximum, but no COVID-19 ICU patients were blocked at the El New Haven Hospital as a result. So it's a bit of a remarkable achievement in what could have been a very difficult situation. A different application. We cannot obviously prevent infections with a vaccine for this disease. We have no vaccines available, and we don't have really good treatments for people who develop serious illness from COVID. Consequently, what we can do is try to stop the spread by isolating persons who have been found infected. And so the goal of viral testing is to detect and isolate new infections. And what we want to do is do this repeatedly to prevent the ignition of local outbreaks. And it really does have to happen repeatedly, because a negative test simply means that a person has not been infected yet. But a positive test means that we can actually block transmission by isolating the infectious individual. So the focus here is on screening for asymptomatic infections to minimize the time from infection to isolation. And we have written actually quite a bit about this as a general strategy, which is only now starting to be pursued because of the logjam on testing that has occurred up until now. I'm going to try and justify this in a couple of simple ways. First of all, the simplest course, I'll call it the 100 level course. This virus is infectious. People are infectious for about a 2-week period, 14 days. If a person is screened weekly, once every 7 days, and the test was perfect, which is not, but let's initially assume that it is, since the infection knows nothing about the testing and vice versa, it's going to occur that uniform over the week. On average, you would be detecting infections at about 3.5 days after they occurred. And consequently, for a 14-day infectious period, on average, you would be blocking 3/4 of all of transmission. You lose the first 3.5 days, but then you gain the remaining time in the 14-day period. Now, tests are not perfect. I suppose the test is only 70% sensitive, meaning that there's only a 70% chance an infected person will be detected, a 30% false negative rate, if you were. So you would only find 70% of persons who were recently infected in their first screen in a given week. However, you still have a 21% chance the next week because of the 2-week period. So you actually end up with almost a 91% chance of detecting a person. However, you obviously won't detect them as quickly, and you'll block fewer transmission days, only about 58% instead of the 75% with perfect testing. Now, the situation actually is somewhat better with weekly screening. The reason is that people are not equally infectious over the course of infection. Initially, people aren't very infectious at all. Then transmission follows a curve like this, which epidemiologists are able to estimate from early transmission data. And so this is a curve that looks like the China curve. And if you detect the person who is infected at a certain point in their course of infectiousness, say with the red line here, you block all of the transmission to the right, which is the area under this blue curve. And you can see that the more frequently you screen, the more to the left this red line goes, the more transmission you're going to block. All right, so even with weekly screening, the location of this line is still going to vary because some people are infected on Mondays or Thursdays, and people are tested on different days, obviously. So this is going to actually be random, but nonetheless, the principle remains. You're trying to block all of this transmission. So now when we put this all together, we consider a model where we have a residential campus, 10,000 students. We say, is everyone susceptible at the beginning? Maybe 20% have already been infected over the past several months, and so only 80% would be susceptible. Suppose the test is 70% sensitive, we can make them more sensitive. Do we screen weekly? Do we screen bi-weekly? Maybe we don't test at all. We have to worry not only about infections generated on campus, you also have to worry about the importation of infections from off campus. Students are going to go off campus, they're going to go to clubs and bars and restaurants and so forth. We want to consider a full range of transmission intensities inside the campus, otherwise they're known as these reproductive numbers. What happens if we basically look at a number of these factors and run a model over an 80-day race from September 1st until the Friday before Thanksgiving? So here's an example where each infected person would only generate 1.5 infections themselves. This is relatively mild compared to the typical values assumed for COVID. But in addition, suppose we have an imported infection coming in daily, then what we would see is with no screening, that's the left axis, we would have up to 20% of the students becoming infected over the 80 days. With biweekly screening, and now scaled to the right axis, we follow the orange curve up and see about 3.5% of the students would become infected. So we've dropped already from 20% to 3.5%, and weekly screening would further drop the number infected down to about 1.5%. But as I said, this is a relatively easy scenario. Now we'll use this reproductive number, which is actually comparable to China. And what we discover is that without screening, almost 80% of the students are infected. Bi-weekly, 12.5%. Weekly screening, we're still down here at less than 2.5%. Now let's really challenge the model. Let's try and up the rate of transmission to a reproductive number of 3.3. This was actually estimated for Connecticut, which, as you probably know, is the third most impacted state in the country in terms of deaths per capita. And now what happens is that virtually all of the students would become infected with no screening. Bi-weekly screening, you still have almost 50% infected. Weekly screening, even in this challenging scenario, keeps the fraction of students infected down below 5%. And of course, we can compare many, many, many scenarios using models like this, not only in terms of how many students are infected, but also in terms of the number of students who must be isolated at any point in time. And what we can see here, just looking at the scales, is biweekly screening simply does not cut it for many scenarios. Weekly screening can control many scenarios. There are still some which are very difficult. Similarly, if we compare the number of isolated students, we see that unless we get into a very difficult scenario, say up to 5 imported infections daily, weekly screening can actually lead to a workable result. So you need to be very, very certain that you would be in essentially this type of a sweet spot if you're thinking about opening campuses and using weekly screening to try and control any outbreaks that would come out. We're not as concerned about the health of the students in a situation like this because they are young. Most of them would be very healthy and experience only mild symptoms. What we're concerned about is that the students, if infected, could ignite transmission change in the local community, and there the situation could result in much more serious consequences. So this is really why we care about repeat screening students. We want to prevent transmission in the community as well as to vulnerable faculty and staff. All right, and the last topic I'll touch on here is environmental monitoring. This was an idea which was raised very early on, March the 6th. The idea was we don't have testing at that time, so the question was, is there any other way that we could actually follow the signal of an outbreak? And to make life much easier for us, we were able to discover an environmental engineering professor a few days after we started looking around, who was very well versed in this area of research, Professor Jordan Petya. We got together with him and a few others a few days later, and we were already collecting data from the local sewage treatment plant on March the 19th, so less than 2 weeks from when the idea first came up until when the sample collection began. So what happens is that every single day, since March 19th, and the study is ongoing now, we have students going to collect sludge samples at the water treatment facility that serves the population of 200,000, New Haven, and 3 of the other surrounding towns. And those samples are then tested for the presence of the coronavirus here. And what you can see using various combination of primers and different sample replications, each of these data sets gives you the shape of an outbreak curve. And if you just look at the raw data, where here what we have is the average RNA that we're seeing in the sludge, telling you what the viral load is, and here we're seeing hospital admissions. If we simply compare the smooth versions of these curves, we see that we get about a 3-day lead time in the signal for the sewage over to hospital admissions. If we do a similar comparison to diagnosed COVID cases, we see that we get more of a 1-week lead time. And if we actually look at an epidemic transmission model here, we see that the transmission model is actually doing a very good job at predicting the timing of what one would see in the sludge. Some people were surprised to see that there would only be a 3-day lead time in the virus observed over the hospital admissions. So the question was, why is that? And it turns out that actually constructing a mathematical model here is very helpful, because on the model scale, you can really show what the different time intervals should be. And so this is basically showing you when incidence would peak, when the RNA observed in the sludge would peak, and when hospital admissions would peak. Now, this is just a model, so we want to compare it to the real data. And when you do that, we get a very strong signal based on the RNA in the sludge. The hospital data don't fit quite as well, they're noisy, but nonetheless, you ask yourself, where is the peak here in the hospital data? Where is the peak in the sludge data? And the sludge data are in fact showing up earlier by about 3 to 4 days in the hospital data. So to summarize here, we can use models to help inform and support decisions. I gave examples about crowd capping, surge capacity for the hospital, repeat screening for university students. We can also use models to help understand transmission dynamics of this infection. The sludge data are a good example of that, and also the repeat screening application. Epidemic modeling is not really about curve fitting. It's not about simply trying to do a prediction of exactly what's going to happen in the future. Rather, it's about navigation through the fog. It's about trying to understand how one can change the course of an outbreak by taking appropriate decisions. Purely forecasting models would basically be about asking what an epidemic is going to do to us, but really what we're interested in is what can we do to control this epidemic, and that's where modeling comes in handy, because through this understanding of the transmission dynamics, it's possible to help assess the likely consequences of alternative decisions or interventions. So that's what I have to share with you, and thank you again for your attention, and I hope you enjoy the rest of the day. Thank you.